Imagine you're a brilliant researcher, right? You've spent years, years, proving some life-changing medical innovation actually works.
hmm Years of work.
How long do you think it takes for that breakthrough, to actually reach the patients, the ones who desperately need it, out in the real world?
You'd hope it would be pretty quick. Days,
Mm,
weeks maybe.
maybe a year or two if things are really moving.
Yeah, exactly. But the surprising thing is, well, frankly, it's kind of grim. The reality laid out in the source we're diving into today,
Hmm.
it often takes much, much longer.
Okay, how much longer?
Estimates suggest it can take around 17 years.
17, wow. 1 to 7. That number just stops you, doesn't it?
It really does.
And that massive gap, that chasm between, like, scientific discovery and actual patient care, that's the core problem we're tackling in this deep dive.
Absolutely. And we're getting our insights here from a really important book, Agile Implementation.
Right, written by Dr. Malaz Boustani, Dr. Jose Azar, and Dr. Craig A. Solid. And it's worth noting, Dr. Boustani and Dr. Azar, they're associated with Indiana University.
Yeah, IU is where a lot of this foundational work, these real-world experiences we'll talk about, actually took place.
So our mission today really is to unpack the early part of their book. We're focusing specifically on the real-world stories and the big ideas they lay out in those first 43 pages or so.
Exactly. Because these experiences, they really show just how tough it is to get great ideas into practice in healthcare.
And they set the stage for why a new approach was so desperately needed.
Couldn't have put it better.
I'm really excited to get into these stories. It feels so critical, for anyone who interacts with healthcare.
Definitely.
Okay, so let's unpack this core problem the book hits right at the beginning. You've got these incredibly passionate people working in healthcare, doctors, nurses, everyone.
Absolutely committed, wanting to do the best.
But they're working inside a system that's just under immense pressure. You think about the constraints.
Oh, yeah. Limited time, budgets getting tighter and tighter, the paperwork, the oversight, it just keeps increasing.
And the direct consequence of all that pressure, plus other system issues, is that shocking 17-year gap we just talked about.
Right. And it's not just some abstract number. It means proven innovations, things we know work from studies, improving health, preventing problems, saving lives. They're basically just sitting there.
Collecting dust on a shelf, almost.
Exactly. Stuck in research papers, not consistently getting into the clinic or to the bedside.
And the flip side of that is, well, while those good ideas are stuck, sometimes ineffective or maybe even harmful practices can just persist.
Because changing things in such complex systems is just incredibly hard.
Yeah. And the book points out the potential outcome, which is devastating. Patients today might not be getting care based on the best, most current evidence.
And sadly, preventable harm, even preventable deaths, can happen because of this gap.
That really gets to the heart of why this matters so much, doesn't it?
It absolutely does. This isn't just about, making things run smoother. It's about a real human cost. It's a systemic failure, fundamentally.
And the knowledge is there?
Right. When we know how to help people more or ease suffering, but the system can't reliably deliver it, that affects you. It affects someone you know, someone you care about.
It really feels like one of the biggest challenges in healthcare today.
Without a doubt.
So the book then kind of shifts gears and talks about the personal journey that really fueled Dr. Boustani's focus on this problem.
Yeah, it's fascinating. It starts with his experience as a doctor, seeing firsthand the huge burden of chronic diseases, especially Alzheimer's and other dementias.
And not just on the patients, but the families, too.
Exactly. He saw how much it took, especially for the family caregivers.
And he realized pretty quickly that the way healthcare was set up, what the book calls Healthcare 1.0, just wasn't equipped for this.
Right. Even with dedicated people, the traditional model lacked the tools, the time, the resources to really handle something as complex as dementia care, including supporting that family caregiver.
He saw families just struggling, right? Carrying this massive weight.
Immense unpaid burden. It really stuck with him.
And that experience pushed him towards becoming a physician scientist focused on brain health. He mentions his fellowship at UNC.
Where he got this personalized guidance, which sounds amazing.
Yeah, really helped him develop as a researcher. Then he was recruited to Indiana University by Dr. Christopher Callahan.
And Callahan became this really key mentor figure for him, more than just a research mentor, like a friend, coaching on leadership too.
Yeah, and using health IT, which is interesting.
And it was at IU then that he and his team did that really rigorous research we mentioned earlier, that randomized controlled trial.
The gold standard.
Exactly. On their new Alzheimer's care model called PREVENT.
And the results were good.
Really good. showed it helped patients reduce their disabilities, and it significantly eased the stress for the family caregivers. Big deal. Published in JAMA.
Okay, so research success, but then plot twist?
Kind of, yeah. It's really interesting. Despite that success, Dr. Boustani actually lost his clinical position. Budget cuts.
Wow, so hitting a wall, basically.
Felt like it, I imagine. But then, almost immediately, this completely different door opens. An opportunity at Eskenazi Health in Indianapolis
To do what?
to build a comprehensive brain health center. From scratch.
Okay, amazing opportunity. What was the catch? There's always a catch.
The catch was the timeline. It had to be up and running, operational, in just 4 months.
4 months to build a whole center.
Exactly. Intense pressure.
Okay, I can see how that would force some creative thinking.
Totally. That high-pressure situation, combined with his growing feeling that the existing ways of managing change things like lean or PDSA cycles.
These are common, right?
Very common. But he felt they were often inconsistent. Sometimes just didn't work well when you applied them to the real, messy complexity of healthcare.
So he needed something different.
He knew he needed something different. He started digging into complexity theory, how interconnected systems behave, looking at other frameworks.
Because building that center wasn't just about following a plan, it was about navigating the unexpected.
Precisely. That intense, real-world need to launch the center quickly, effectively, plus his scientific curiosity about why some changes stick and others don't. That's what drove him and his colleagues, Jose Azar and Craig Solid, to start building their own model.
Which became Agile Implementation.
Agile Implementation. So that journey itself really highlights why a better way was needed, something built for the complexity of healthcare.
Okay, so that sets the stage perfectly for part 1 of the book, which uses these real-world case studies.
Yeah, they're not just abstract examples. These are powerful stories from their actual work at IU and Eskenazi.
And they really illustrate the challenge, right?
Yeah.
How hard it is to take something proven in research and make it work day to day.
They show the friction points, the unexpected hurdles, the lessons learned from actually doing it, not just theorizing about it.
So let's dive into the first case, the Healthy Aging Brain Center, the HABC. You mentioned Alzheimer's care earlier.
Right, and the book makes this crucial point. When you're caring for someone with Alzheimer's, you're essentially caring for two people.
The patient and the unpaid family caregiver.
Exactly. And the load on that caregiver is just enormous. Hundreds of hours a month impacting their own health, their job, everything.
And at Eskenazi Health, like most places, standard primary care just wasn't set up for that dual complexity.
No, and a big reason was the way healthcare is paid for. National billing, reimbursement. It just didn't cover the kind of intensive support and coordination needed, especially for the caregiver.
So, huge unmet need. But the evidence for a better way was already out there.
It was. That PREVENT study from IU we talked about, and a similar one from UCLA, had already proved that a collaborative care model worked.
Collaborative meaning different professionals working together.
Yep. Doctors, nurses, social workers, the whole team. And the study showed it reduced patient disabilities and caregiver burden. Solid RCT results published in JAMA, gold standard.
Okay, so they had the what. They knew what worked.
Exactly. And what's so fascinating here, the book emphasizes, is that the real hurdle wasn't proving the model worked. It was figuring out how to actually implement it.
How to get it off the ground in their specific hospital, Eskenazi Health.
Within that complex system, and yeah, under that crazy 4-month deadline.
So what did they do? How did they start?
They pulled together a really diverse team. Physicians, geriatricians, nurses, social workers, neuropsychologists, the experts on brain function and behavior, you name it.
Okay.
And their first big job was to define the minimum specifications. Like, what are the absolute essential core components needed to deliver that PREVENT care model in the real world?
Minimum specs. Keep it focused.
Exactly. The book lists 7. Things like education and support for patient and caregiver, regular needs assessments and care plans, managing other brain conditions, handling medications, coordinating care.
So the core elements. And how did they structure the actual care?
Basically 2 phases, an initial assessment phase, often phone calls plus clinic visits, then ongoing follow-up care, both face-to-face and phone.
And crucially, they built in a way to learn as they went, right? Adapt.
Yes. Regular performance feedback, looking at clinical outcomes, looking at costs, and they use that data to adjust.
Is there an example of that?
Yeah, a great one is the neuropsych testing. Initially, they thought the nurses and social workers could handle doing these detailed cognitive tests.
Okay.
But they quickly realize, uh-oh, this is stretching them way too thin, creating bottlenecks, slowing everything down. An unintended consequence.
Right. So what do? Stick to the plan rigidly?
No, they adapted pragmatically. They realized they needed someone dedicated to it, so they hired a new staff member just for the neuropsych testing.
Which probably increased costs up front.
It did, a bit. But it made the whole process way more efficient, freed up the nurses and social workers to do their main jobs, and actually boosted staff satisfaction. It was the right move for the system overall.
And the HABC was successful.
Very. Effective disability management, lower caregiver burden, even cost savings for the health system. And it's kept evolving. HABC 2.5, nurse helpline, using tech.
So the big lesson from HABC, as the book puts it.
The biggest challenge wasn't finding the effective model. It was the operationalizing and implementing. Making it work in the real world. Defining those minimum specs was key to making it adaptable.
Okay, that makes a lot of sense.
Yeah.
Let's move to the second case. The Critical Care Recovery Center, CCRC, for ICU survivors.
Right. So medicine's gotten better. More people are surviving critical illness, which is fantastic news.
But there's often a but.
There's often a but. A big problem emerged. Many survivors leave the ICU with significant, long-lasting issues. Cognitive problems, physical weakness, psychological trauma, like depression, PTSD.
Wow. And the book mentions a study at Eskenazi.
Yeah, finding really high rates of patients ending up back in the hospital or even dying after surviving things like acute lung injury or delirium in the ICU, a serious downstream problem.
So from the hospital's point of view, this wasn't just about patient suffering, which is huge, but also...
There was real pressure from the administration. For one, more critically ill patients overall, but also new government rules started hitting their bottom line.
Like penalties.
Exactly. Financial penalties if patients were readmitted within 30 days of discharge. Suddenly, there was a clear business case for doing better post-ICU care.
Ah, okay. So that led to creating the CCRC.
Yes, and they smartly used the HABC, the Brain Center, as a model, pulled together another interdisciplinary team, blending critical care and geriatrics expertise.
Because many ICU survivors are older.
Makes sense. And they used that Agile implementation process they were developing for their strategy meetings, again, defining the minimum specifications for the CCRC.
What were those specs? Similar ideas?
Similar logic. Things like maximize patient recovery, enhance patient and family satisfaction, smooth out that transition from hospital to home, and key for the admin, reduce unnecessary hospital readmissions and ER visits.
And this is where they used sprints. What are those?
Yeah, this case really highlights sprints. Think of them as short, intense, focused cycles. You test one specific part of the plan locally, quickly see what happens, and adapt right away.
Can you give an example?
Sure. They had a big problem with patients not showing up for their first CCRC appointment after leaving the hospital. High no-show rate.
Okay, so they used a sprint?
Exactly. They tested simple changes in short bursts. Things like having the ICU team make the referral before the patient left, and having CCRC staff call patients beforehand to explain why the visit was important.
And did it work?
Immediately. Significant drop in no-shows. So they learned quickly what worked and scaled it up. Rapid learning and adaptation.
And they tracked everything.
Oh yeah. Robust monitoring, patient outcomes, satisfaction, and those system metrics, readmissions, ED use, costs, all on dashboards.
And the results?
The book mentions early results showed improvements in outcomes and less costly utilization. And importantly, the CCRC is still going strong years later, adapting, even exploring home-based care.
So CCRC reinforces the HABC lesson.
Strongly. Again, the challenge wasn't just the evidence-based approach, it was the how. Implementing it effectively, sustainably. Sprints and minimum specs were key tools for navigating that complexity.
Okay, third case study. Reducing central line-associated bloodstream infections, CLABSI. This one starts pretty intensely.
Yeah, the book uses this really powerful, tragic story. Mr. Smith, successfully treated for cancer with chemo via a central line.
Which is common, right? That line in the chest.
Very common. But just before going home, he develops an infection from that line, a CLABSI, and tragically dies.
Oh, wow. And it was preventable.
Largely preventable. It's a devastating reminder of the stakes in patient safety.
And CLABSIs are a big problem nationally.
Huge. Tens of thousands a year in the U.S., high costs, high mortality. They're a major focus for quality monitoring. Hospitals get penalized for high rates.
And like the other cases, we kind of knew what to do already.
Exactly. Evidence-based guidelines, prevention bundles, sets of steps for inserting and caring for the lines they existed. The issue wasn't the knowledge, it was the consistent execution. Every time, everywhere.
So IU Health Academic Health Center saw this, saw the potential for tragedies like Mr. Smith's.
And made CLABSI reduction a top system-wide priority. They understood the stakes.
What was their approach? Similar team structure.
Yes, another interdisciplinary team. Doctors from different areas, nurses, pharmacists, infection prevention experts. Their job was to take the national guidelines and adapt them for their specific hospitals.
Make them local.
Right. They developed localized guidelines, a clear checklist for inserting the lines, and this seems really key, a training curriculum.
But not just teaching the steps.
No, explicitly designed to improve the interactions and communication between all the different staff who had to work together. Doctors, nurses, techs, different backgrounds, sometimes different priorities, getting them on the same page.
And the book highlights their focus on engagement, right?
Massively. They put huge effort into getting buy-in from leaders and frontline staff, using storytelling, sharing Mr. Smith's story, showing local data.
To build genuine motivation.
Exactly. So much so that the training wasn't even mandatory at first, but they trained hundreds of doctors and over 1,000 nurses really quickly because people wanted to do it. They understood why it mattered and felt supported.
Wow. And how did they keep it going?
Through ongoing implementation sprints. Unit leaders met regularly, using this simple but powerful Agile format. What worked well, what didn't, what are we going to do differently next time?
So constant learning and accountability at the unit level.
Shared accountability, yeah.
Yeah.
They use visual dashboards too, and really leverage their infection prevention specialists to dig into why things were happening, looking at behaviors, attitudes, team dynamics, even just making sure supplies were easy to find.
And the monitoring was broad.
Very comprehensive. Not just CLABSI rates, but other infections too. CIUIs, SSIs, C. diff plus falls, medication errors, looking for system-wide impact.
And the results were good.
Really impressive. CLABSI rates dropped over 50%. And other infections and harm events decreased too.
And the key takeaway wasn't a new invention.
No. The book hammers this home. Success came from how they implemented established guidelines in their unique setting. The focus was on people and process.
And the staff feedback was crucial here.
Absolutely critical. Staff said the success was driven primarily by feeling more engaged and by a shift in the whole culture.
From what to what?
From potentially punitive, fear of reporting errors to a culture of teamwork, open learning, shared accountability, and everyone feeling responsible for safety.
So if we connect that to the bigger picture,
it powerfully shows that successful change in these complex healthcare systems often boils down to improving how people interact, how teams function, the overall culture.
And they saw spillover effects.
Yeah, the idea that focusing intensely on improving CLABSI care likely lifted the boat for safety and quality in other areas too. Because these units aren't isolated silos. Changes ripple through the system.
Which really makes you think about where to focus improvement efforts.
Exactly. The key lesson from the CLABSI story. Successful interventions have to embrace the complexity, the uniqueness of the people, and leverage those things. How people work together is just as vital as the clinical guideline itself.
Okay, so let's bring these three stories together. HABC, CCRC, CLABSI reduction. What's the common thread weaving through all of them?
The common thread is crystal clear. In every single case, the main challenge, the biggest mountain to climb, wasn't a lack of evidence for what to do clinically.
They had the proven solutions.
They had the proven solutions. The overwhelming challenge was figuring out how. How do you successfully, consistently, and sustainably implement that solution in the real, messy, complex, ever-changing world of healthcare? With real people, established habits, constant pressures.
The how was the hard part.
The how was the desperately hard part. And these experiences, grappling with that complexity, the variation, the critical role of human behavior in team interactions, these were the building blocks.
The things that showed them the old ways weren't enough?
Absolutely. They revealed the limits of traditional, more rigid change methods and screamed out the need for something new, something adaptive, designed specifically for that healthcare reality.
And that leads right into the next part of the book, right? Around
Sure.
page 43.
Exactly. That's the transition point. Part I gives you the compelling why through these stories. Then part 2, starting around page 43-45, dives into the what and how of the theory.
The underlying science.
Right. Things like behavioral economics, how people really make decisions, not always rationally, and complex adaptive systems theory, how all these interconnected parts interact and adapt, often unpredictably.
So the theory explains why the experiences, in part, happened the way they did.
Precisely. It provides the scientific foundation for the Agile implementation model itself. It shows why this specific approach focusing on adaptation, minimum specs, sprints, engagement, why it's designed to actually work in healthcare's complex environment.
Okay, so wrapping up this deep dive into just the first part of Agile implementation, the big takeaway seems to be, well, it's hard. Getting good ideas into practice is incredibly hard.
Astonishingly hard, yeah. That 17-year gap isn't an accident.
The stories of the HABC, the CCRC, the CLABSI Reduction, they show it is possible.
Definitely possible. But success isn't just about having the right clinical idea. It hinges on understanding the system's complexity and really focusing on the how of implementation, how it happens on the ground with the people involved.
The process matters as much as the intervention.
At least as much, yes.
So maybe a final thought for you, the listener, to chew on.
Yeah, given how complex we've seen healthcare delivery is and how genuinely challenging it is to implement even proven changes consistently, what does this mean for your expectations?
When you interact with the system, or when you hear about big plans to improve healthcare.
Right. How much attention do you think is really being paid in those plans to the critical how of actually making change happen successfully on the ground? Something to think about.
Definitely something to think about. Thank you for joining us for this deep dive.